gaps and make the world a safer, better protected place. This week, we're celebrating a big deal. 100 countries have now completed the Joint External Evaluation, the world's best indicator of how prepared countries are for the next epidemic.
This is a huge landmark in our preparedness work to make sure the world is better protected against the threats that we face.
This incredible success reflects the remarkable multi-sectoral engagement and effective collaboration towards understanding the capacities of countries to prevent, detect and respond to health emergencies.
In Uganda we had one in 2017 and it has really informed our health security. It has improved our regional collaboration, our regional coordination.
Metrics are great, but now it's time to do something about it. We need to make sure that they're doing national action plans.
To use the GE findings in closing the gaps that have been highlighted.
Let's take a moment to celebrate this success. It's a big deal. And let's return with even greater urgency to fill the gaps and make the world a safer, better protected place.
I had only a colleague, and that colleague happened to be my boss. That was Dr. Patrick Onguku. And we were the only two staff. I was the cleaner, I was the driver. The only official car we had was actually my car.
Of course, it started with a series of short courses to address surveillance and outbreak, interestingly funded and supported by the WHO. So the actual first advanced graduates were recruited on 20th October 2008. There were 13 in number. It was very interesting. 3 lab scientists, 4 veterinarians, and 6 medical officers. So it was interesting for the first time, these 3 disciplines learning together.
Every year, Dr. Patrick will say, Chinya, I don't know whether we are going to be able to take the next year. But we've taken the second, we've taken the third, and today we've taken the 10th cohort. And even at the start of 10th cohort, it was still the same thing. Are we sure we are going to be able to take the 10th cohort?
I think NFELTP has given me a lot. The program has trained me to become a field epidemiologist that I am today. I'm very proud to be a graduate. I'm very happy to have passed through this program. I believe the sky is the limit for the program as we continue to collectively implement actions that will improve public health in our dear country.
Yes, I'm one of the privileged few that is a graduate of the program. FELTP is a program because it's expected that it's going to last for a long time. It's not a one-off project, it's more of a program. So the robustness of its training and its quality is such that any program area, service area, HIV or non-HIV, polio, non-polio, any other form of it, you already have the basics, the rudiments that you need to excel in that area of focus. So I can say FELTP itself is an interventional program. It can help you further strengthen your existing public health system with strong focus on epidemiology and laboratory strengthening.
I was not disappointed at all because, with the mentorship, the exceptional mentorship we had in the program, the excellent faculty that took us through the courses, and the fact that it was a well-oiled machine, a very good program with international connections, with network to ensure quality control and the rest of that. I have no regrets. In fact, I consider my education in field epidemiology as the best thing that has happened to my intellectual life within the last 10 years.
I'm glad 10 years after, it's stronger, it's bigger, it's broader, it's more integrated in the ministry, in NCDC, in Ministry of Agriculture, and it's sort of advanced some of the initial objectives of having a skilled workforce for surveillance and outbreak, responding to outbreaks in an adequate and timely manner, but also providing evidence for public health decisions, as well as networking.
In 2012, the National Stop Transmission of Polio was created within the Nigeria Field Epidemiology and Laboratory Training Program to use NFELTP structure to strengthen polio eradication in Nigeria. The first thing that we did in 2012 was to sit and think, who are the personnel that can manage and stop, that can contribute to polio eradication in Nigeria in a different way. So we looked at staffing and decided that there's a need to have a pool of highly trained, culturally competent local staff that could be the game changers for polio eradication in Nigeria. So NSTOP has a pool of about 35 epidemiologists that are all graduates of NFELTP.
The impact of the Nigeria Field Epidemiology, Field and Laboratory Training Program in Nigeria has been profound. Many people would refer to the epidemiology that they've been involved in, the response to the Ebola outbreak, the response to many outbreaks, their leadership roles in states and local governments, and in disease programs in Nigeria. But really, for me, the important thing and the critical thing is that we're building a whole genre of leaders, people that are thought to think differently, to challenge the status quo, to look for solutions, disease detectives, leadership, a leadership cadre of a new Nigeria that we are trying to create. So for me, this is a really profound group to be associated with.
Good evening, ladies and gentlemen. You're all welcome to the formal opening ceremony of the 4th NCDC NFELTP Annual Scientific Conference. We'll start with the national anthem. Are you ready? Can we rise for the national anthem? Have our seats. Thank you. So we'd like to start by introducing the dignitaries who have come to grace this opening ceremony. I'd like to start with the Honorable Minister of State for Health, Dr. Olorunnibe Mamora. You're welcome, sir. Next, we have the Honorable Minister of Agriculture and Rural Development, represented by Dr. Ezenwa Nwakonobi, who is the head of Animal Health and Clinical Services in the ministry. Then we have the Director General of NACA, Dr. Aliyu Gambo Gumel. We have the Executive Secretary of the National Health Insurance Scheme, Dr. Mohamed Nasir Sambo. The DG MODHIP, Brigadier General Okeji. The CDC Country Office Director, represented by Dr. Bolu Omotayo, who is the Director of the GID program. Then the Acting Executive Director of AFENET, Dr. Simon Antara. Then the representative of the Director of Africa CDC, Dr. Mohamed Abdulaziz. You know, we have two universities collaborating with FELTP, so we have some highly placed officials from the university, the Deputy Dean of the School of Postgraduate Studies, Ahmadu Bello University, Professor Okubanjo, and the Dean of the PG School from the University of Ibadan, represented by Dr. Kayode Samuel. So it's time to take some goodwill messages from some of the partners who have been supporting this program right from the beginning and are still solidly behind us. We'd like to start with the Acting Executive Director of the African Field Epidemiology Network, Dr. Simon Antara. Before Simon starts to speak, I actually left out our guest speaker for today, the special speaker for today, which is Dr. Faisal Shuaib, who is the Executive Secretary of the National Primary Healthcare Development Agency. You're welcome, sir. We're looking forward to hearing you speak so much that we forgot to mention your name. Yeah. So, Simon, are you ready?
The Honorable Minister of Health, the representative of the Ministry of Agriculture and Water Resources, the Director General of NCDC, Director General, National Agency for the Control of AIDS, the Executive Director, National Primary Health Care Development Agency, the Executive Secretary, National Health Insurance Scheme, distinguished guests, ladies and gentlemen, I bring you greetings from the Africa Field Epidemiology Network, AFINET. The Nigeria Field Epidemiology and Laboratory Training Program is a member of AFINET. The role of the program in public health workforce development and public health intervention is well known. No doubt, the program is doing a great job at fulfilling the purpose for which it was established. A forum such as the NCDC NFELTP annual conference to share the good work that is done here with stakeholders and partners, and doing so consistently is commendable. On behalf of the AFINET Board of Directors, management, staff, and all the AFINET member programs, we say congratulations. May I say a word or two about two key issues that have always consumed the attention of all who are involved in field epidemiology capacity development. Continuous quality improvement is key towards maintaining the continuous relevance of any field epidemiology training program. A high-quality program which is contributing significantly to the national and global public health agenda is a program with a guaranteed longevity. The NFELTP submitted itself to the definite accreditation processes and emerged successful. The program is accredited. In simple terms, what that means is that the program has in place systems to ensure its quality. So certainly, you are doing well when it comes to quality. But remember that the room for improvement is never full. There is the need to continue to invest in quality improvement. And here I want to reassure you of AFINET's commitment to continue to support in whatever way possible. The second issue I want to talk about is that of sustainability. The increasing relevance of field epidemiology capacity, the increasing demand for field epidemiology is universally acknowledged. Unfortunately, funding for field epidemiology capacity development is continuously waning. At the AFINET Ministerial Roundtable held in Dar es Salaam in 2011, and here in Abuja in 2016, African health ministers resolved to mobilize funding to support field epidemiology capacity development. From the reports that we have, many countries are yet to walk the talk. In the midst of all this, it is encouraging to note that Nigeria is taking the lead, showing the way and doing things differently. Your ownership of the program, not just by words of mouth alone, but by your deeds, your actions, and infusion of resources is exemplary. It is worthy of emulation. You are doing very well. But again, remember that the room for improvement is never full. Finally, to all the partners that have been supporting the NFELTP, you will agree with me that you made the right decision to invest in this program. You have done very well, but again, remember that the room for improvement is never full. Thank you very much.
Thank you, Simon. I'd like to call Dr. Bolu Omotayo from USCDC to give a brief goodwill message.
Good afternoon. afternoon. All protocol duly observed. Thank God we didn't have to call the accident an emergency a minute ago. The Honorable Minister for State for Health, Dr. Mamora, all protocol observed. I think Dr. Antara has really spoken. There is really room for improvement. Dr. Mahesh Swaminathan, who's the country director for USCDC, is unavoidably absent, and he passes his goodwill messages. First, the USCDC is extremely excited to be a part of this. The NFELTP has been going on for several years, and USCDC has really supported it. It's born out of the Epidemic Intelligence Service Program, the one which I also took part in. And frankly, for the residents, that's the best thing you can do. It opens windows of opportunities beyond your imagination. And having that field epidemiology training program here in Nigeria, with all the outbreaks that we see, not just in Nigeria, but in Africa, gives you fantastic opportunities to learn, to implement, and actually to go forward in your career. The other thing that we would like to share with you from the USCDC, seeing that this is really a program we take extremely seriously, is the fact that sustainability has become a big issue. I really must commend Dr. Chikwe and his team for the work they've done in absorbing the NFELTP program. They really must be commended for it. It's not an easy process, but they've taken it on hook, line, and sinker. Resources are definitely needed. Streamlining the resources on what needs to be done, what can be done, what needs to be done, what to be cut out is key. But for a country to take on this program with the amount of outbreaks we see is no small feat. And I would really like to also plead, even with the government of Nigeria, NFELTP needs to be institutionalized. Just as we have the School of Pharmacy or School of Laboratory, that institutionalization of the field epidemiology training program with resources attached to it is going to be so key, not just for Nigeria, but for Africa in general. The residents are seen supporting not outbreaks only in Nigeria, but all over the world. NFELTP residents are helping out in different countries, and it's no underestimate. So again, to the government of Nigeria, and I'm looking at Dr. Mamora, that please help us to make sure that this program is institutionalized and well-funded going forward. And to the residents, what I would like to say, as I mentioned at the beginning, please do not stop learning. Every opportunity for an outbreak response, you have to take advantage of it. The data analysis, the data quality, writing your reports, consistently writing is only going to take you further. We, now that I've moved to the global immunization program, I must admit we've taken advantage of all these residents with the polio response, but also any outbreak we call upon, they are there to help us. So on that very short note, I would like to say thank you to giving us this opportunity. The USCDC remains highly, highly behind you in terms of supporting the activities, from the Global Immunization Division to the Division of Global HIV Protection to HIV/AIDS, all the difference to the malaria program. All the divisions at CDC are so keen on helping this program move forward. And once the government takes over, our support would not stop, in kind or in cash. So thank you very much.
Thank you, Dr. Omotayo, for that message. So before we take the next two goodwill messages, I'd like to recognize the presence of some other partners that we have here. We have Dr. Tosan Irabo, who is the Executive Director of the Medical Laboratory Science Council of Nigeria. We also have the representative of the National Veterinary Research Institute, VOM, JOS. They've been very supportive of the program right from the beginning. So this program was established with a memorandum of understanding between the Federal Ministry of Health and Federal Ministry of Agriculture and Rural Development. So I'd like to call upon the representative of the minister, of the Federal Ministry of Agriculture and Rural Development to give his goodwill message.
The Honorable Minister of State, Federal Minister of Health, Dr. Mamarasa, the DG NCDC, may I please stand on all the existing protocols. On a personal note, I am not an NFELTP product, but I've benefited so much from the program. Two of my key staff in Animal Health and Clinical Services Division, Dr. Charles and Dr. George, are products of NFELTP. What I have here is a message from the Honorable Minister of Agric, Alhaji Mohammed Sabo Nanono, and I've just read the message as it is. Thank you. It is my pleasure to attend this fourth NCDC NFELTP Scientific Conference with the theme, Applied Epidemiology, Providing Evidence for Public Health Action. I am equally happy to see that the NFELTP has continued to sustain the One Health spirit, as evidenced by the turnout today of an array of professionals from the medical, laboratory, and veterinary sectors. Since 2008, the Federal Ministry of Agriculture and Rural Development has collaborated with the Federal Ministry of Health and two universities, Ahmadu Bello and University of Ibadan, under the NFELTP program to train veterinary, medical, and laboratory personnel to respond to public health events around the country. Graduates of the program have made a huge difference in responding to disease outbreaks and surveillance in the context of One Health. It pleases us in the ministry that to date, about 81 veterinarians from different federal MDAs and the states have been trained under the program, including the current Chief Veterinary Officer of Nigeria, Dr. Olaniro Alabi, who was in the first cohort of the program. Despite the giant strides of the program, there are still areas that need to be looked into by the collaborating ministries and other stakeholders. One of those areas is the issue of sustainable funding. We are aware that USCDC has been graciously supporting the program for the last 10 years, but that support has drastically reduced, and there is a need for us as a country to look inwards to raise much needed funds to sustain the program. I want to assure you all that the Federal Ministry of Agriculture and Rural Development is committed to playing its collaborative roles and responsibilities to the NFELTP, and we continue to engage with all stakeholders in this regard. Another area that is pertinent to us as a ministry is for the veterinary residents to carry out projects under the program that are in line and directly related to the priorities of the veterinary services. This will ensure that such projects help to find solutions to our numerous local veterinary challenges and not just carrying out academic exercises that will be left on the shelf. This year's conference theme, Applied Epidemiology, Providing Evidence for Public Health Action, is apt, especially for us in the veterinary sector. Contemporary public health challenges like monkeypox, Ebola, Lassa fever, yellow fever, which are related to animals, and most of the time come from animals, are some of the zoonotic diseases that call for applied epidemiology with a One Health approach. Over the next 2 days of this conference, we hope to see presentations that speak to the theme of this conference, so we can have meaningful deliberations that will help provide solutions to our public health challenges. I thank you all for listening and wish you a happy conference. Thank you.
We'll also take brief messages from the two universities in alphabetical order. We'll start with Ahmadu Bello University, Zaria. That's Professor Okubanjo.
Ministers, sirs, I stand on the existing protocol. Good afternoon, everybody. I bring you greetings from Ahmadu Bello University through the School of Postgraduate Studies. We in ABU we do not talk too much, but we will give you the action. And on that note, we are pleased to stand with this program as we have done right from inception. We have supported them, and we will support them. It is our wish to contribute our quota to making humanity a better place. And anything that is worth doing, we will make sure that we do it very well. I can also assure you that this program is also an enviable one, because the graduation rate has been quite good, and it has been done within the stipulated time. So I want to congratulate you on that. Again, we are also fortunate that this time around, the Dean and the Dean's representative of PG School, in my humble self, is also a vet. So you can see that the support will be enormous. Like I said before, we will stand by you, and you can be assured of the best interest of the Ahmadu Bello University. Once again, thank you very much, and congratulations.
From the University of Ibadan, Dr. Kayode Samuel.
The Honorable Minister of State, and I stand on also established protocols. I bring greetings from the Postgraduate College, University of Ibadan, the first. Yes, I'm sure we are expecting me to complete it. And the best. Thank you very much. I will just join the last speaker to say, in the academia, you know, apart from just speaking, it's in the doing, and the evidence is there. The University of Ibadan will continue to be the beacon and cooperate with us, collaborate with us, and continue to build the requisite manpower towards achieving the goals, the objectives that have been set for this program. And so we are glad and always ready and happy to join you as partners, even in achieving all the objectives that have been set, based on the agreement that we have. I'm a man of very few words. I thank you. God bless you.
Thank you, sir. It's time to invite the Director General, the Nigeria Center for Disease Control, Dr. Chike Ihekweazu, to give his welcome address.
Shakir, I've been learning my name and surname for 3 years. Anyway. Honorable Minister of State for Health, Dr. Olunrimimbe Mamora, we tried. Executive Director of MPHCDA, my brother, Dr. Faisal Shuaib, Executive Secretary, National Health Insurance Scheme, Professor Mohammed Sambo, Director General, National Agency for the Control of AIDS, Dr. Aliyu Gumel Gambo, the Executive Director, Medical Laboratory Science Council of Nigeria, Mr. Tosin Erabo. Thank you very much. Just to pause here before I continue, I think it says a lot about the new dawn in the health sector that so many heads of agencies and the minister is on at this panel, at this conference today. So thank you very much, my brothers, for attending. Representative of the Director of Public Health of the Federal Ministry of Health, representative of the 2 universities with whom we collaborate in the delivery of this program, the Acting Executive Director of AFENET, Country Director of USCDC, directors, colleagues at the USCDC, representatives of partner agencies, my colleagues at the Nigeria Center for Disease Control and AFENET, and everyone that has played a role in the development and delivery of the 4th NCDC NFELTP Annual Conference. I welcome all of you to this occasion. Good afternoon, ladies and gentlemen. I am very honored to welcome you to the 4th NCDC NFELTP Annual Conference. It's the 4th time we're doing this, and yes, there have still been some hitches for which we apologize, but we keep trying to do better every year. The last time we met here for the 3rd conference and the 10th anniversary of NFELTP, the bill for the establishment of the Nigeria Center for Disease Control was going through the legislative process of the National Assembly. In November 2018, President Muhammadu Buhari signed that bill into an act. Today we have the legal backing of a full agency of the Federal Ministry of Health. Perhaps one of the most critical aspects of that bill to this audience is our role in the leading of the implementation of the Nigeria Field Epidemiology and Laboratory Training Program, NFELTP, a responsibility which we have taken with a profound sense of responsibility. We know that we stand on the shoulders of giants building on the work done over the past 10 years, and we are fully ready to take the program into the future and make sure it's a sustainable part of the delivery of the public health workforce in Nigeria. Since the establishment of the program 11 years ago, we have made progress, including having a strong One Health approach as the basis of its implementation. We work very closely with the Ministry of Agriculture in the delivery of Nigeria's FELTP program, as well as in response to the outbreak of zoonotic diseases. As part of this conference this week, we have been developing new surveillance guidelines for anthrax and brucellosis, 2 important zoonotic diseases. This is with the support of a group called the Global Implementation Solutions, one of the new partners we have brought on to support us on this journey. We have spent the best part of yesterday in 8 different workshops sponsored by our partners at Resolve to Save Lives, Public Health England, the US Defense Threat Reduction Agency, Japan International Cooperation Agency, the West Africa Health Organization, WAHO, the Tony Blair Institute for Global Change, BioMirror, and eHealth Africa. It was important for me to be at almost every workshop yesterday, as I found the topics deeply insightful and the audience engaging. We're grateful to all our partners. Without you, this conference would not be possible. I am particularly grateful to the new Africa Centers for Disease Control for funding a major part of this conference. The World Health Organization country office remains a strong partner, and we're grateful that they have provided travel grants to some to attend the conference. In addition, I'm deeply appreciative of the support of the Bill and Melinda Gates Foundation in the delivery of this conference being able to be held in this beautiful venue in Abuja. So between today and tomorrow, we have a unique opportunity to listen to an exciting lineup of speakers, many who have traveled from far and wide to be with us today. I am specifically and exceptionally grateful to my brother and friend, Dr. Shuaib, the Executive Director of the National Primary Healthcare Development Agency, who is our keynote speaker this afternoon. And in addition, deeply grateful to the collaboration that has developed between our agencies as we work on Nigeria's health security together. We also will have insightful presentations of various aspects of work done by staff of NCDC, residents, and graduates of the program, as well as several other colleagues working in aspects of public health. Many of these colleagues have been groomed and taught by the excellent faculties of the University of Ibadan and the Ahmadu Bello University in Zaria. The NCDC NFELTP conference presents an opportunity to network, to learn more about our various organizations at the exhibition booths and stands, and most importantly, to engage in critical thinking and discussions that will drive the future of field epidemiology in Nigeria. Finally, I would like to thank the new leadership of the Federal Ministry of Health, the Honorable Minister, Dr. Sagie Ehanire, the Honorable Minister of State, Dr. Lorumibe Mamora. In one of his first interviews, the Honorable Minister said about a month ago, openly declared that health security will be one of his major focus areas. This gives us an opportunity and hope to increase Nigeria's position and improve our position in global health, in the global health security matrix. At the Nigeria Center for Disease Control, as a science-driven organization, we continue to strive to live up to our vision, to have a science-driven agency. Our work can only be effective if we build collaboration and partnership to support each other with the federal ministries of health and agriculture, state governments, epidemiologists, scientists, and the entire workforce that makes up the health security architecture of Nigeria. We are, as always, stronger together. Thank you very much.
Thank you, the Director General, for that very inspiring welcome address. Before we go to the next item, I'd like to recognize the presence of Dr. Noel Chisaka, who is a Senior Health Specialist and Task Team Leader of Redice Program, World Bank Headquarters, Washington, D.C. Where is Noel? Yeah, so before we get to the pièce de résistance of this afternoon, which is the talk from Dr. Faisal Shuaib, we'd like to take a brief video interlude. Just 5-10 minutes. Thank you.
This week, we're celebrating a big deal. 100 countries have now completed the Joint External Evaluation, the world's best indicator of how prepared countries are for the next epidemic.
This is a huge landmark in our preparedness work to make sure the world is better protected against the threats that we face.
This incredible success reflects the remarkable multi-sectoral engagement and effective collaboration towards understanding the capacities of countries to prevent, detect, and respond to health emergencies.
In Uganda, we had one in 2017, and it has really informed our health security. It has improved our regional collaboration, our regional coordination.
Metrics are great, but now it's time to do something about it. We need to make sure that they're doing national action plans.
To use the JEE findings in closing the gaps that they've been highlighted.
Let's take a moment to celebrate this success. It's a big deal. And let's return with even greater urgency to fill the gaps and make the world a safer, better protected place.
That was just like 1 minute. I'd like to call my colleague, Dr. Abiodun Egwenu, to introduce our speaker for this special plenary session. Abiodun, are you ready for it? Yeah.
So I'll be introducing Dr. Faisal Shuaib. Dr. Faisal Shuaib is a medical doctor and public health specialist and is currently the executive director of the National Primary Healthcare Development Agency, NPHCDA. Prior to this, he was a senior program officer for the Bill and Melinda Gates Foundation at Seattle, USA. At the BMGF, Dr. Shuaib was responsible for developing and implementing strategies on polio outbreak response activities in Africa. Prior to joining the foundation, Dr. Shuaib coordinated Nigeria's successful response to the outbreak of Ebola virus disease, EVD, as the incident manager of the Ebola Emergency Operations Center in 2014. He was also a member of the 6-man panel established to assess the response of the World Health Organization to the global outbreak in 2014 and provided technical advice to the Federal Ministry of Health and NPHCDA in areas of immunization and polio eradication activities between 2012 and 2015. With a warm round of applause, please welcome with me Dr. Faisal Shuaib.
Your Excellency, the Honorable Minister of State for Health, the Director General of the NCDC, my brother and friend, Dr. Chikwe Ihekiazu. I know I didn't call that nearly as well as Shakir did, but forgive me. In the interest of time, I will stand on already established protocol. But really, Honorable Minister, Dr. Olorunimbe Mamora, it's really an amazing time that we find ourselves in this place and in this venue. I've been in this space since 2012, and really when I came in and I saw really the configuration of the hall and the people that are here to mark this fourth event, it's so amazing how NCDC has really come since 2012, and I think we need to give a round of applause to Dr. Chikwe for his leadership. If I was not gainfully employed, really, this is where I would really want to work. So today, we've had at NPHCDA the distinct honor and privilege to present to you the journey towards ending polio in Nigeria. Today's opportunity to speak to you about the journey to end polio eradication, of course, comes from so many years, so many decades, over 20 years of hard work trying to cross the finish line in a number of places, number of times we were successful, but we also had drawbacks. But today, we mark so many years of efforts that has brought us to 3 years without a single case of wild polio virus. Next slide. So in this presentation, I've sort of talked us through the past, the present, and the future to try and really describe the journey of polio eradication. Next slide. This slide really talks about the chronology of polio eradication initiative in Nigeria, starting from the pre-1985, when polio killed over 500,000 people annually globally, to when in 1955, the inactivated polio vaccine was invented, in 1961 when we had the oral polio vaccine, OPV, and in 1979 when, very importantly, Rotary International became involved in polio eradication. In 1985, Rotary Polio Plus launched with an investment of $120 million US, the first initiative to globally eradicate poliomyelitis. And this led to 1988, when the Global Polio Eradication Initiative was launched in the World Health Assembly. By 1988, we were aware that some 125 countries had over 350 cases of wild polio viruses occurring every year. But really, we started making a headway in Nigeria in 1996 after President Nelson Mandela launched the Kick Polio Out of Africa program. Since then, we launched the house-to-house campaign that I'm sure everybody is familiar with in 1999. We made steady progress towards interrupting wild polio virus until in 2003, when concerns about the safety of the oral polio vaccine led to the suspension of all forms of oral polio vaccination in Kano and Zamfara states. Of course, the result of that was that we had the resurgence of the wild polio viruses paralyzing our children. Since then, I'll talk a little bit more about how we overcame that. But you are aware that in 2012, the Presidential Task Force on Polio Eradication was launched by President Jonathan. And since then, we also had the National Polio Emergency Operations Center that was set up on the recommendation of the Expert Review Committee on Polio Eradication and Routine Immunization. Important landmarks, of course, around the fact that we used the polio eradication program to fight Ebola in 2014. And there's no doubt that one of the single most important reasons why we were successful with the polio eradication program and Ebola outbreak response in 2014 was because of the boots on the ground. And who were the boots on the ground? It was largely the NFELTP program. Your Excellency, Honorable Minister of State for Health, I want to use this opportunity to say that, yes, we lost about 8 people during the Ebola outbreak response in 2014, but it was such an outstanding response that was globally recognized. However, despite the hard work, dedication, and commitment of NFELTP residents, they have not been duly recognized. So I will request that we set aside the politics that permeated the country in 2014-2015 that prevented NFELTP residents from being recognized. Let's undo the wrong and recognize people who were involved in the in the Ebola outbreak response. In other countries, similar work has been recognized with national awards. I think it is not too late, and it is better late than never. I'll quickly leave the issue of the recognition. I hope that my prayers have been answered by the Honorable Minister of Health. To talk about the setback we had in 2016 as a result of insecurity in the Northeast that led to an outbreak of white polio viruses in Borno, and the immediate release by Mr. President of 9.8 billion naira to quickly control the outbreak. And it was because of that swift leadership that has brought us here today, 3 years without a single case of white polio virus. In the ensuing period, we've had results of routine immunization in Nigeria shared by the MixNIX data that showed that although we were doing so much in polio eradication, we did not do so much in routine immunization. We'll talk a whole lot more about what this really means for polio eradication. Next slide. This slide talks about the trend in polio virus from 1990 to 2019. See how we started with almost 2,000 cases of kids being paralyzed by the white polio virus in 1990 to 0 kids being paralyzed for 3 consecutive years. It's amazing when you also consider the fact that there are 2 other polio endemic countries, Pakistan and Afghanistan, who are now seeing an unprecedented increase in the number of white polio viruses in their countries. And you can recognize that, of course, when it comes to technological advancement, we're nowhere close to countries like India and Pakistan. So really, this is an amazing feat as a result of all the work that all our stakeholders here have been involved with. So critical, really, to why we got here. It is not a fluke. It is not a coincidence. One of the major reasons why we were able to cut down on the number of white polio viruses and we're at the point of being certified as polio-free is because we established the National Polio Emergency Operations Center. So the polio EOC is very, very central to why we are here. And this is why, for me, it is very important that NCDC has established many emergency operations centers that will manage outbreaks of different diseases, learning from the polio program. So really, as you are well aware, with the emergency operation centers, using the incident management approach, we are moving from vertical interventions to an integrated service delivery, multiple investments without a strategically focused approach to addressing health issues, to prioritization of high-impact interventions and innovations. We're moving from just focusing on the inputs to really focusing on system processes, outputs, and outcomes. With the incident management approach, we're moving from a time when there's poor data management, utilization, monitoring, and evaluation to more performance review, incentives, and management. We're moving from a fragmented approach within departments and agencies and across sectors to integration of programs, coordination of results, and with clear lines of accountability. But very importantly, we hold our workers, our staff, accountable for the work that they do. And we'll now move from a largely public sector focus to really working with academic institutions and the private sector. Next slide. So what is an emergency operations center? I know you guys can give me a lecture on emergency operations center, but very central to the functionality of an emergency operations center, and I think this is why it has worked in Nigeria. in Pakistan and Afghanistan, they came to Nigeria to learn how we established and the functionality of the polio EOCs. Unfortunately, they've not been as successful in the implementation of the incident management approach and the EOCs like we have. Very central to the running of the EOC, of course, is that government leadership. That you have government leadership and the development partners work together with the government, understanding, agreeing around a single plan and an implementation process. Next slide. Again, I'm sure you're familiar with what this EOC approach is. But really, it is using a war room model, bringing everybody together with high intensity in terms of the way work is done, giving very strict timelines, holding people accountable for the work that they do. So it's not a question of having a meeting and then you do not leave the room with clear understanding of what needs to be done, who needs to do it, and by when. This is really the single most important thing that the EOCs have brought to public health in Nigeria. Next slide. So in summarizing, the question that will be forming in your minds right now is, why and how did we succeed? How can it be that you look at different sectors of Nigerian life and you can really pick and choose a few success stories? Why is the polio eradication program a success story? Well, these are some of the reasons why we have become successful with the polio eradication program. One, like I mentioned earlier, the establishment of the emergency operation centers, the introduction of programmatic strategies such as the hit and run in the insecure areas of the Northeast, the directly observed polio vaccinations, and then for a very long time, we did not understand how the viruses were moving around Nigeria until, under the sponsorship of the USCDC, we launched the Nomadic project, and we're able to map the routes of nomads. And we found that the nomads were closely associated, the routes of the nomads were closely associated with where we found outbreaks. And that was a huge revelation that made us now focus on how we will vaccinate people around these roads. I'm sure that the N-stoppers and the folks that have been working in the Nomadic project, can we give them a round of applause? So, of course, we also went one step further to use GIS technology. So we're able to, for example, know where vaccinators were not going. So for a long time, there were instances where you will give vaccinators vaccines and say, go to the most rural areas, cross rivers, climb mountains, and they will just go and hide somewhere, tabulate the numbers and say, we're finished vaccinating. Oh, today was a very difficult day. Meanwhile, they did not go anywhere. But with GIS technology, we're able to give them phones, we're able to track our vaccinators, and we're able to know if they actually went to those sites where they were supposed to give vaccinations, because we're able to see on a dot map whether these vaccinators actually got there. And that made a huge difference. So when you say you have gone to those places and we check and you are not there, we'll show you you were not there. And then when you go, we show you that you were actually there. So there was no more hanky-panky. So here we are in a developing country using first world type of technology to ensure no child is left behind. Next slide. So I'll talk a little bit more about, I mentioned earlier the Ebola response. One of the reasons why we were successful with the Ebola response was because we had an active polio eradication program. So we used exactly the polio eradication template and moved to Lagos and Port Harcourt using the NFELTP residents that went from house to house to look for contacts of Ebola cases. That made a huge difference. Unfortunately, when the story of Ebola is narrated, not a lot of people talk about the amazing work that was done by the NCDC, by NFELTP residents. How many of you have watched 93 Days? No, you guys need to go and watch 93 Days. Not a single mention of all the work that the NFELTP residents did. And I had a big fight with the producers of that movie. So they say they are going to have a part 2. So you should watch out for it. But this slide just shows my 5 minutes of fame on CNN after the Ebola response. I found this on the internet, so I thought I should bring it here. And to also show some of the NFELTP residents that were doing house-to-house contact tracing. Please give them a round of applause. Next slide. So let's talk about the present. That is all in historical terms. In terms of the present, where are we with polio eradication? Next slide. Well, this slide just talks about the fact that we prioritized polio eradication when we came on board. Next slide. I know one of the questions that will be on your mind is, here we are in 2016, we had a setback. How can we be sure that this will not happen again? Since 2016, when we had the outbreak in Borno State, we've worked with the military to go settlement by settlement in the program we call the Reach Every Settlement Program, mapping all the settlements where there is partial access, partial insecurity, and making sure that every child is vaccinated. See how well we have done. In all of the settlements, some 4,500 settlements that we've mapped, we've been able to reach some 99.5% of these settlements, making sure that every child living in this settlement has oral polio vaccine. The next slide shows what we call the Buratai Initiative. Next slide. So with the Buratai Initiative, this one is still the RES. Is the next slide. Okay, so with the Buratai Initiative, we're working with the military because there are places where we just can't go, no matter how dedicated and committed we are. We love Nigeria, we want to eradicate polio, but there are places where, you have to leave it to the military. And this is why we established the Buratai Initiative. Of course, Buratai is the Chief of Army Staff, working with the military. Once the military evacuates places in insurgent-controlled areas, oral polio vaccine is given to the children as they come out, along with other health packages. And what we've seen is a gradual increase in terms of the number of kids that we've been able to reach. These were the kids that caused the outbreak in 2016. Those kids that we could not reach. So we said, never again are we going to be so overconfident that we have reached everywhere. So we made sure that we continue to reach every child in even the most insecure areas. So we give the oral polio vaccine to actually the military men, and we have some of the photos, maybe in another, this is not in a different presentation, showing the military men actually vaccinating kids. So 3 years without white polio virus, but this is just a milestone. Again, we're cautiously optimistic, knowing that there's another process of certification that is required, right? So we've gone 3 years without the white polio virus being reported anywhere, but there are regional bodies that will have to come and certify that we have good enough surveillance, our routine immunization is good enough, and that we're not missing any cases. So this slide really talks about, again, the wild polioviruses over time. But one thing that we've been experiencing of late are the circulating vaccine-derived polioviruses, which are really a direct result of poor routine immunization and poor environmental and personal hygiene. Next slide. So this is just some information about polio certification. The criteria for certification, I've talked about intensifying surveillance, and I think this is where our collaboration with the NCDC will be very, very critical towards ensuring that we get certified as polio-free. Next slide. Again, these are some of the timelines to the certification process, hopefully by March 2020. In the interest of time, I'll just flip through this. Next slide. Now, this slide just talks about the circulating vaccine-derived polio viruses that we're having. So far, we've had about a total of 66 cases. Next slide. And this is where these circulating vaccine-derived polio viruses are. Again, they are a direct result of poor routine immunization. So where we have poor routine immunization, this is where you have circulating vaccine-derived polio viruses. I know in the course of the last 10 years or so, for those who have been following the data, the data around, in Nigeria is not very, very reliable. Well, it hasn't been very reliable until maybe recently when we now have, the NCDC providing better data, NPACDA also providing data. There was a time in Nigeria where, routine immunization coverage was 120%. So even before a child is born, they've already immunized that child. No, absolutely. And I've seen papers where where such information has been published. If you talk, they say it's because of the population. But it is not true. The truth of the matter is that health workers in the primary healthcare centers, they were padding the data. And I like to say that even before they started padding the budget in the National Assembly, in the health sector, we were already padding data. So that was the issue. So we were not true to ourselves. So when the surveys were made, when we conducted surveys, right? Surveys will show that our routine immunization coverage was around 40%, 30%. We will say, no, it's not true. It is 120%. Meanwhile, we continue to have outbreaks. You have measles outbreak. You ask, but why are you having measles if you are having 120% coverage? There will be silence. There's no answer. So, of course, these are some of the indications that routine immunization has been very poor, right? And the mixed-NICS survey, the multi-indicator cluster survey, the National Immunization Coverage Survey of 2016-2017 showed that only some 33% of our kids had received Penta-3 vaccine, clearly indicating that we had suboptimal routine immunization coverage. Next slide. So at NPACDA, after the mixed-NICS survey, we declared an emergency and said, enough is enough. We will stop lying to ourselves that we have 120% coverage. If the surveys indicate that it is only 33% coverage, we accept it. We know we're not doing very well. Those are stumbling blocks, but we use those stumbling blocks as stepping stones to progress in routine immunization. So we set up the National Emergency Routine Immunization Coordinating Center, NERIC, with the following objectives: to improve detection and responsiveness to RI gaps, to strengthen coordination, improve data visibility and accuracy, and to increase access to routine immunization. Next slide. See how we're making progress towards reaching 85% coverage in the next 10 years. We totally believe that we will surpass historical trends and actually reach 85% coverage long before the next 10 years. Next slide. So, again, these are some of the things that NERIC has done. In the interest of time, I'll not go through this. I'll share these slides, and we're happy to receive you at NPHCDA, in the spirit of the collaboration that exists between NPHCDA and NCDC, where we can show you, what we've been doing to try and address the routine immunization gap. We now conduct what we call the lot quality assurance sampling to assess how well we're doing with routine immunization on a quarterly basis. Again, why is this important? This is important because if we do not improve routine immunization, then we will not be able to stop the circulating vaccine-derived polioviruses, and that means we will not be able to be certified as a polio-free country. So really, this context is very, very important. So with the lot quality assurance sampling, next slide. So every quarter in 18 very priority states, we do this lot quality assurance sampling that shows red, meaning you are doing very, very badly. Brown, that shows you are doing badly. Yellow, you are doing badly, but green, showing. So in the places that are green, it shows that the kids are being vaccinated very well, and the places that are red is very, very poor. Again, in the interest of time, I don't want to go into all the details, but really, back up one slide. If you look at the slide from left to right, you can see how increasingly we're having more green LGAs and less of the red, right? This information is from the second quarter of 2018. Recall, we established NERIC in 2017. And see how the work of NERIC is directly impacting the number of kids that have been vaccinated in Nigeria towards helping control circulating vaccine-derived polioviruses. Next slide. So in terms of the number of LGAs, see how we've moved from quarter 2 of 2018, where we had only 111 LGAs passing the LQAS, to more than doubling the number, right? More than 100%. So we're having increases in the number of green LGAs and less of the reds and the browns. Next slide. Again, for the priority 18 states where the routine immunization was worse, see how we've moved from the top right quarter 4 in 2017. If we move towards the right, you can see how from predominantly red LGAs, you are beginning to see more green LGAs. To the bottom left, where you see, this is in quarter 2 of 2019, where you see more green LGAs, indicating that more LGAs have more kids that are being vaccinated appropriately for their ages. Next slide. Again, this is a depiction of the map that I just showed. Next slide. So what does the future portend for us after polio eradication? What are we going to do with all the resources that we've built over the last 2 decades when it comes to Nigeria? Well, what the future portends for us at NPHCDA and the partnership is that we now have to look at indices such as our maternal and child health indices. Nigeria ranks, as I'm sure you're well aware, among the countries in Africa with the worst maternal and child health indices. This is why we declared an emergency on maternal and child health in April of this year. 147 women, pregnant women, die every day in Nigeria as a result of pregnancy-related causes. That is equivalent to having a plane crash of pregnant women every single day. I want that to sink in for a little while. But it will not make the front page of the national dailies. You know why? Because most of those women are very poor and they live in the rural areas. By the same token, some 2,300 children under 5 die every single day in Nigeria. That is equivalent to about 15 plane crashes of children under 5. Again, there are poor and vulnerable kids, and nobody is asking tough questions about why it is happening in Nigeria. This is what we're going to be using our polio resources for. Once we are certified as polio-free, we have to look maternal and child deaths in the eye and really scale up our interventions. It is a serious problem, but somehow it is not in the front of our consciences. And this is why at NPHCD and the partnership, we say we have to really deal a blow to maternal and child deaths. When you are in the US or Europe, if a woman is pregnant, she will say she's pregnant. The next question that they ask her is, are you having a boy or a girl? In Nigeria, is that the same question that they ask a pregnant woman? They say, may God deliver you safely. In all of your languages, that is the next question, that's the next thing that comes. Like you are embarking on a dangerous journey. But that is the reality of the life that the poor people live in Nigeria. Next slide. So finally, we can just, again, this is all about what we're doing at NPHCDA. Even before the polio resources are available, we've set up an incident command system to try and look at the problems, the 4 delays that really cause the deaths of women, and then how we can rapidly bring down these numbers within the next 2 years. Next slide. Again, we've done the LQAS again to have a look at, what is causing all of these deaths, and we have proxies for these maternal deaths, the antenatal visits, and then skilled birth attendants. The problem is with the skilled birth attendants. In a place like Zamfara, in a state like Zamfara, 95% of the women deliver at home, and that is where the deaths occur, right? So people, you can see many more green on the left plane. So women go for antenatal, but when it comes to delivery, they prefer to deliver at home, and that is where you see so many reds, and that is where women are dying. Next slide. This is really to talk about our technical support unit, how we're using polio resources to provide dedicated support to the states. Next slide. This is around PHC revitalization. This is around really the final slides. I wanted to use this platform and this opportunity to clear the air about primary healthcare revitalization. So when the Federal Ministry of Health espoused this policy of revitalizing 10,000 primary healthcare centers, approximately 1 primary healthcare center per ward, the intention, the vision was never for the federal government to go to all your communities and renovate and refurbish and revitalize the primary healthcare centers there. This was supposed to be a joint effort between the federal government, the state government, the local government, the non-governmental organizations, and the private sector. But these days you hear, they say, federal government promised us 10,000 primary healthcare centers. We haven't seen one. It's a collaboration that is supposed to be. The federal government cannot do it alone. And this revitalization goes beyond just painting, renovating the primary healthcare center. It means having the right human resources, having the right drugs and commodities, having utilities, making sure that there's community engagement. So there's still a lot of work that needs to be done. But this work we have to do together as stakeholders trying to strengthen primary health care. Next slide. Next slide. So I leave you with the challenges that we still face in terms of really finishing the job of polio eradication. We still have challenges with insecurity. We still have challenges with places where there are kids that are not getting the vaccines that they need. We have challenges with the vaccines, especially IPV. Counterpart funding is a problem. Sometimes when there's a campaign, the counterpart fund does not get released until after the campaign is over. It is part of what we see in everyday Nigeria. We see a lack of accountability in the implementation of some of our programs. But really, while these challenges exist, the great ingredient that we have that gives us hope at NPACDA and the partnership is the human resources. The fact that if you give Nigerians the resources, you give them the leadership, Nigerians will deliver. In every walk of life, if you put these ingredients into play, you'll find that Nigerians come on top. This is why we're this close to being certified as polio-free. This is why, for us at NPACDA, we believe in the vision of Dr. Chikwe and NCDC. We believe in the NFELTP program. We believe in the collaboration between the federal government of Nigeria and our development partners. And we have no iota of doubt that in the next few years, we'll see a transformation in the health sector. Thank you very much.
Thank you, Dr. Shuaib, for that talk. So you are not to leave the stage yet. Dr. Patrick just reminded me that he has something for you.
Thank you so much for that keynote address. For each of our keynote speakers, we have something to remind you of your contribution, but for you specifically, the collaboration between NCDC and the National Primary Healthcare Development Agency has been phenomenal. So I would like to ask Dr. Chikwe, the DG, to come over and just hand over a small award from us, but also take a picture of the two of you as a sign of commitment that after polio, there are other diseases, for example, preventable diseases, measles, tetanus, diphtheria, and others, CSM. But there's also the non-communicable diseases. Today is the World Suicide Prevention Day, reminding us that there's more work to be done. So thank you so much, and with your transformative leadership, I know we will conquer it.
It's time to take the remarks from the Honorable Minister of State for Health, Dr.
I have a written speech here, but before going into that written speech, I would just like to make a few comments. And I will start from Dr. Fisa. Thank you for those jabs. Okay? But I can assure you that they're in good faith, and we are in it together. The glory is not in never falling. The glory lies in rising after each fall. And we do it better, can I assure you. Then, from your presentation as well, you observe that the heroes in the fight against Ebola are yet to be recognized and honored. Part of our national anthem says, the labors of our heroes past shall not be in vain. And that is also applicable for these heroes of the fight against Ebola. I make a commitment on behalf of the Federal Ministry of Health that their labors shall not be in vain. We will make a case for these heroes at the highest level of government, highest authority in Nigeria. That's a commitment that I stand here to make on behalf of the Federal Ministry of Health. A grateful heart never forgets good deeds. So the good deeds of these heroes will not be forgotten. Well, I bring greetings from the Honorable Minister of Health, Dr. Hanire, who would have loved to be here, be part of this great occasion. The two of us will have been here, but you know the way it is, commitments here and there. But he sends his greetings to this house and this august gathering. So, I think I can then go into the speech. And in so doing, you will permit me to identify with the protocol already established, and I believe appropriately, by Chikwe. I prefer to just stand on Chikwe. I won't go further so that I don't get into trouble. I am delighted to welcome you all to the 4th NCDC NFELTP Annual Scientific Conference. This conference, organized by our National Public Health Institute, the Nigeria Center for Disease Control, and our Nigeria Field Epidemiology and Laboratory Training Program, is the largest gathering of field epidemiologists in Nigeria. Perhaps more than we have previously realized, the world views applied epidemiology as a critical function for public health action, in addition to conflicts and displacement. In Nigeria, we have continued to experience large annual outbreaks of Lassa fever, cholera, and measles, as well as clusters of cases of yellow fever, meningitis, and monkeypox. It is clear that changing environment and population dynamics, along with improved capability to detect infectious cases, are also increasing. Therefore, we need to build resilient health systems and continuously work on improving them to prevent, prepare, and detect, respond to, and control these infectious disease outbreaks. A critical part of this resilient health system is the human resource. Our field epidemiologists, laboratory scientists, managing physicians and nurses, program managers, and all health workers. I am proud of our field epidemiology program now in its 11th year, with over 300 graduates. The government of Nigeria, through the Federal Ministry of Health, Federal Ministry of Agriculture and Rural Development, has shown great leadership and commitment towards a sustainable training program led by the country. The NCDC is the agency with the mandate to lead the implementation of the NFELTP and has continued to grow and show dedication to improve this critical program. I am grateful to all partners who support this conference, and especially the U.S. Centers for Disease Control that helped midwife the birth and still continues to support the growth of Nigeria's NFELTP. We are only as strong as our weakest link. It is in supporting each other as countries that we are able to make progress towards strong